we test that and just make that distinction? What kind of tests are there for that?
So there's a couple different tests that we can look at. To me, I use three main types of tests in my analysis of work. You've got NAAT tests, or nucleic acid amplification tests.
Yeah.
This is kind of the classic swab in the nose. You've got a rapid agent test that is kind of like the strep throat swab that everybody knows of, that gives the classic plus or minus, yes or no, like a pregnancy test.
Yes.
And then you've got these serology or antibody tests. The antibody tests are very cool because they can tell you if you've got it and you're sick now, or if you've had it and you've got maybe a little bit of immunity to it, or if you've had it and cleared it and you were thinking, wow, I never even had any symptoms at all.
Right.
That's very interesting. So I think you need a mosaic pattern of all three of these and use them at the right times and the right locations. But typically the nucleic acid tests and the serology tests are your two biggest players that you're going to want to pay attention to, I believe.
And so that NAAT test, is that the same as a PCR or the polymerase chain reaction that people are hearing and learning about and seeing in popular media?
Yeah, they are. They're a PCR, polymerase chain reaction, is a way to take a small amount of DNA, or in this case, RNA from the virus. And I know I'm also talking to a virology expert, so you mind me, please, ma'am. But you take that swab, and it's got a little bit of the virus's RNA particles, like DNA, but it's just a virus. So this one uses RNA. Yeah. You've got a little bit of that virus particle on that swab from the nose or the back of the throat. And you use PCR to make more and more copies of it. You take one or two and you grow it into 20,000, and then you test those copies. So it is kind of, the way I think of it, is making a copy of one bad monster a million times over, so it's easier to count them.
Count it.
That's how that plays into consideration.
Well, you said that's the nasopharyngeal swab. What is that? And somebody's actually asking, why does the test burn? Is that the test that burns?
Anytime you stick a swab in the back of my throat through my nose, it's going to burn. I've had it done. It's not pleasant. You're getting deep. You're going in through the nose to the back of the head, in the back of the posterior oropharynx. It's an invasive test. It's not pleasant. I wouldn't want to do it for fun. And it typically triggers these eyes. You get lacrimation because all these nerve endings are kind of really close congested in your head. So you're scraping all these things, and it's an unpleasant test, but it gives a lot of vital information. Sadly, there's been a lot of literature coming out recently that really shows that nasal pharyngeal swab in the back of the throat is better than just in the back of the throat, like a strep throat swab test. So unfortunately, and then you've got an even deeper test where you can do it into the lung, and that gives better results. But man, the more invasive you get, the better your sample. But, I don't really want a swab stuck that deep into my body if I'm, unable to avoid it.
So sunflower oil, why does the test burn, make your eyes run water, and make you cough after? This was my experience after getting the test done. So it sounds like that's exactly what you're describing, Dr. Erik.
Yeah, what you're doing is this is going in through your nose into the back where your nose and your mouth meet, in the back of your posterior oropharynx. That's why sometimes when you go, you can get snot into your mouth. It's that communication back there that you're going into. It's invasive, and you're triggering oftentimes a gag reflex. So you get that involuntary retching, which causes lacrimation and that whole kind of catecholamine release of fight or flight, because something invasive is deep down in your airway and your body's trained to push it out. Yeah. So that's a healthy body's response to a crazy test.
You alluded to some tests being better than others. What do you mean by better? What makes it better?
Good question. Better means higher rates of true positives and lesser rates of false negatives. So what we're looking at is, there's this concept that we talk about in epidemiology called sensitivity and specificity. And this basically talks about people who really have the disease, and the test confirms they have the disease. You're not getting false positives. And then you've got sensitivity that looks at negatives in the disease, and you want to avoid false negatives. So we want that sweet spot of both. that tests somebody that shows, yes, he has the disease and the test proves it, or no, she doesn't have the disease and the test proves she doesn't have it. The swabs from the nasal pharynx are the best. They have the highest sense and spin for both.
Oh, no. So that means then we're not really close to being able to test just saliva or just blood to look for active infection, huh?
So there are some tests out there now. Everybody hopefully is familiar with the FDA, the Food and Drug Administration. They monitor and kind of give guidance on testing. They have a thing called an EUA, Emergency Use Authorization. This is kind of their stamp that says the test is met their standards and it's good to go. Now, you don't have to have an EUA by the FDA, a lot of abbreviations, to start administering your test to people. But what we're looking at is the difficulty in creating a test. We're looking at the difficulty of, how invasive of a test is it? How quickly can we get the results? And I think it was last week, a saliva test came onto the market by a commercial laboratory that amplifies DNA or RNA in this case, and allows you to do the same type of testing. That's a lot easier. I think you're going to have better compliance. If you ask people to show up and you're going to get a stick shoved down the back of your nose, or you can spit in a tube, I'm going to spit in the tube every time. But you have to weigh this off with the efficacy and validity of your test. So I think that's important.
Yeah. And how efficacious or valid is that particular test? Do we know the saliva one so far?
It's not as good as a nasopharyngeal test, sadly. The nasopharyngeal test is, and I'm not even going to use the term gold standard. The nasopharyngeal test is one of the best tests we have out there, but compared to a test for HIV, or compared to a test for HPV, or some of these other viruses that we're used to dealing with, we're light years away from getting a good quality test in a responsible amount of time that people are going to saddle up and take.
Yeah. Does that mean if somebody has a high suspicion for being infected, and even the nasal pharyngeal swab is negative, they should still presume they're positive?
Yes. There's a high rate of false negatives. I'm not going to mention the specific manufacturer of a test that's widely used right now, but they're having a much higher rate in real life clinical scenarios when you're getting tested in the ED or your urgent care or your family doctor's clinic. They're seeing more false negatives than were originally expected when the test rolled out. And that's unfortunate because it gives a little bit of false security. It gives a little bit of ideas that, I don't have it, and maybe I can go out and do other things. And that gets into a dangerous area. False negatives are just as bad as false positives.
Yeah.
And this test is seeing a lot more false negatives. One of the beliefs behind this is it's a little bit user dependent of how deep are you able to get that into the oropharynx. If you just stick it in the anterior part of the nares right there, well, you're not going to get as good a sample as if you get it all the way back in there deep. So a lot has to do with the validity and experience of the person doing the test and how compliant the person is. If they pull their head back in the middle of it,
right?
Yeah. That brings me to another good point about, the idea of the number of tests performed aren't always the number of individuals getting tested. So, and I don't mean to play with words, and I'm not a lawyer, but if you're doing 50,000 tests a day, you could only be testing 5 individuals, or vice versa. So the number of tests done doesn't mean you're testing all individuals with that same frequency and number. So I think that's an important distinction as well, man.
Meaning some people can end up getting the test more than once.
Yes. And sadly, as we're learning about this, you're seeing people that, I got tested 3 times and they were all negatives. And then when I was intubated and put into an ICU, that's when my 4th test became positive.
Yes.
Would have been nice to have known that a little bit ahead of time. And those false negatives and false positives are really playing havoc. We're struggling to get a quality test.
Yeah. So what would be a quality test? And if, for example, that nucleic amplification test has this false negative rate, does it make sense to combine that with what you described earlier, the serology or the antigen test? Is there benefit to combining them?
You're thinking like an epidemiologist now, doctor. I love it.
I've been watching you and listening to you long enough.
Yeah. So we like these two-step tests. You know, we like using a quick, rapid point-of-care test that I can get, ideally, in a perfect world for me. We'd have a test result that's simple, easy to do. We do the nucleic acid amplification, and we get a test that is a pretty good specificity and a pretty good sensitivity. So we've got a fair rate of true positives and a pretty low rate of false negatives. That's a good screening test. But then we usually, like with ELISAs and Western blots, for example, with, I'm going to say syphilis. Okay. Yes. We want to do a screening test, and then we want to confirm that, like with HIV. Okay. Yes. So we want to do a test that screens, and we can throw a big blanket out over the community on, and then confirm this with our serology testing. Yes. Serology testing is incredible. The technology is amazing. This is not testing the antigen or the virus particle. This is testing my own body's immune response to having fought the virus sometime in my past. And we look at these little things, they're called immunoglobulins, and you're going to hear people talk about IgG and IgM. Right. All right. When I was in med school, my last name is McLaughlin, so I remembered IgM is the biggest one, and it's the one that fights the first. Yes. I like to think of that in me, right? I'm modest. I like it. So IgM, you see in your serology test, your IgM will peak high in the beginning phase of your illness and then drop off. And then as you start to recover, your IgG goes up. And the IgG can be used, very excitingly, to look back and see, like, when I was a kid, I had chicken pox. I'm old enough that I actually got chicken pox. I have, or I should have, an IgG titer in my body that proves biologically Erik fought the chickenpox virus when he was a boy. Now that gives a world of new information to us, man.
Yes. And so, speaking of which, to my knowledge so far, the FDA hasn't really approved a serology test yet there are lots of tests out there on the market. How are they working, and do you see any so far, without naming names per se? Are there any antibody tests out there on the market that you now think are, up to par for what we're looking for from them?
Yes, I think there are. These are, as a scientist, I like yes or no. I like positives or negatives. I like the demonstration of there are IgG titers, and I want to see how high they are, and I can measure those. There are tests out there that are able to do this. They're cumbersome, they're awkward to roll out, and this is what we're fighting now, is getting this technology everywhere. Yeah. There are some tests out there, World Health Organization is another body, because I practice globally. World Health Organization is another body that I follow, and I look at their literature, and they are advising screening with NAATs, and then using your real-time PCR to amplify this, and then I'm expecting them very shortly to come in and say that you're going to confirm this with your serologies, your IgGs and your IgMs. And I see us going that way. Sadly, here we just lack both tests. We need. Why is that the world that we built? That's a good question. That's probably a question more for someone that's in an elected official capacity. For me as a doctor, I want tests. I want them for patients that need them. I want them for patients that maybe not need them, so we can better understand how big that table size is in the room. Yeah. There were a lot of complexities in developing a test like this. We previously had a good nasal amplification test that we were able to run like a panel of respiratory viruses that we typically run in the emergency departments, and that gives us a good broad example of, you have influenza A, influenza B, influenza B, RSV, human metapneumovirus, a couple other flavors of the other coronaviruses that make people sick each year, rhinoviruses, things like this. This was a new bug. This was a new virus that we struggled to get. There were complications with some of the federal testing entities that rolled out with reagents, because, you don't just swab the test and it magically tells you your answer. You have to put some other chemicals on the test, let it cook, kind of like baking a cake. and get your results at the end of it. And you have to have good quality chemicals you put on your swab, good quality sugar, flour, water. It all goes into getting a cake with a valid result. And if one of your steps in that test is off, the whole thing has gone to pear-shaped.